Hi, my name is Katie Lovett, and this is my Case Connections Unit 4 video. I chose to do my case study looking at cases 1 and 2. I'll start with case 1. This case involves a newborn female who appeared normal at birth but then developed lethargy, hypothermia, and apnea within 24 hours after delivery. The doctor treating this patient suspected a metabolic disorder and decided to order a panel of labs. They must decide which diagnostic test would be best to distinguish between a urea cycle disorder and a beta oxidation disorder. Beta oxidation disorders are characterized by multiple inherited defects that usually manifest during fasting with hypoglycemia, or low blood sugar, and metabolic acidosis. Signs and symptoms of metabolic acidosis include nausea and vomiting, lethargy, and hyperpnea. Although the patient is exhibiting lethargy, she has not vomited, and she is exhibiting apnea rather than increased depth and rate of breathing. Urea cycle disorders, on the other hand, are classified as inborn errors of metabolism, which are caused by a mutation that results in one of the 6 urea cycle enzymes being deficient. These enzymes are responsible for removing from the bloodstream, removing urea from the bloodstream. Therefore, the lack of this important enzyme leads to hyperammonia. When this ammonia in the bloodstream reaches the brain, it can cause severe and potentially irreversible brain damage. Newborns with severe mutations can become dangerously ill within 24 to 48 hours of birth, which matches the situation with this patient. The rising ammonia levels in the blood will eventually lead to lethargy, hypotonia or low muscle tone, respiratory distress, and seizures.
Thank you.
Hey Maddox, I'm recording a video for class.
Oh, sorry.
That's okay.
Can I get something first?
Sure.
Thank you.
Sorry, it's my son coming to get something. The diagnostic test that would be best to distinguish between a urea cycle disorder and a disorder in beta oxidation would be plasma glutamine, because glutamine is a non-toxic and non-essential amino acid that plays a role in the detoxification and transport of ammonia. Therefore, plasma glutamine levels should also be elevated if the patient does in fact have a urea cycle disorder. Glutamine levels would be normal if the patient's condition was related to a disorder in beta oxidation. The other blood tests would not be the most appropriate choice in the case of this patient. A serum fatty acids test is useful when evaluating for uncontrolled diabetes, or conditions that involve excessive release of lipoactive hormones such as epinephrine, norepinephrine, glucagon, thyrotropin, and adrenocorticotropin. Testing urinary acids is useful in diagnosis and managing patients who have inborn errors dealing with organic acid and amino acid metabolism, along with defects of the urea cycle and the mitochondrial respiratory chain. Obtaining a blood glucose level alone in this case would not be comprehensive enough to warrant diagnosis. Results from the full blood workup for this patient showed an elevated initial blood ammonia level of 314, which rapidly rose to 600. Normal blood ammonia levels range from 17 to 80, so hers were clearly very elevated. Her urine uric acid level was elevated at 473, while normal levels range from 0 to 3. The patient's plasma citrulline level was normal at 10, with a normal range of 12 to 55. Based on the information provided by this lab report, the patient appears to have ornithine transcarbamylase deficiency, known as OTC. This is an X-linked recessive urea cycle disorder, which is characterized by complete or partial deficiency of the enzyme ornithine transcarbamylase. OTC is one of the 6 enzymes involved in the decomposition and removal of nitrogen in the body, which is known as the urea cycle. The lack of this enzyme disrupts the body's ability to clear nitrogen from the system, which results in excessive accumulation of nitrogen in the form of ammonia in the blood. Excessive ammonia is a neurotoxin, and it travels to the central nervous system through the bloodstream, resulting in symptoms such as the ones experienced by this patient, including vomiting, lethargy, respiratory distress, and difficulty regulating body temperature. The enzyme least likely to be impaired in this condition is carbamoyl phosphatase synthase 1, known as CPS1. This enzyme catalyzes the synthesis of carbamoyl phosphate from glutamine, or ammonia, and bicarbonate, using energy from ATP. It constitutes the first step in pyrimidine and arginine biosynthesis in the urea cycle, which is why this enzyme would not be impaired, because it plays a role early on in the cycle before ornithine transcarbamylase. Case 2 involves a 4-day-old female who will be identified as patient A for the purpose of this case study. Patient A's birth weight was 5.9 pounds, and both the pregnancy and vaginal delivery were without complication. Her newborn screening results showed a phenylalanine level of 6.6, while normal range is within 1 to 2 milligrams. She was tentatively diagnosed with phenylketonuria, PKU, and additional samples were obtained for further evaluation. Patient A's parents deny a family history of PKU. Phenylketonuria is an autosomal recessive disorder which is caused by deficiency in phenylalanine hydroxylase, known as PAH, which is the enzyme responsible for converting phenylalanine to tyrosine and other important compounds in the body. The occurrence of PKU varies among ethnic groups and geographic areas. In the U.S., PKU occurs in approximately 1 in 10,000 to 15,000 infants. Luckily, most cases are detected shortly after birth through routine newborn screenings, and treatment can be started to avoid the severe signs and symptoms of the disease that can develop if left untreated. PAH, the enzyme, is a mixed-function oxidase because it includes one atom of oxygen into the hydroxyl of the product, tyrosine, and another atom of oxygen into water. If dietary phenylalanine is not processed properly, this leads to increased levels of phenylalanine in the blood. This phenylalanine is an amino acid that is obtained primarily through dietary proteins and can also be found in some artificial sweeteners, such as in diet soda. When phenylalanine builds up in the bloodstream, it causes intellectual disability, behavioral problems, and developmental delays. A patient with high phenylalanine levels produces higher concentrations of phenylpyruvic acid, phenylactic acid, and phenylacetic acid, which results in PKU and can also result in schizophrenia. The signs and symptoms of PKU can vary greatly, ranging from mild to severe. The most severe form of the disorder is known as classic phenylketonuria. Infants with classic PKU will seem entirely normal until a few months of age, when they begin to develop symptoms such as seizures, stunted growth, hyperactivity, skin conditions such as eczema, tremors, or a musty odor of their breath, skin, or urine. Diagnosis includes plasma amino acid analysis showing increased phenylalanine without increased tyrosine, a uterine pterin analysis, and red blood cell dihydropteridine reductase, SA, can identify pterin defects. Pterin defects cause early severe neurologic disease, such as developmental delay and seizures. The amino acid tetrahydrobiopterin, known as BH4, will become an essential amino acid in the case of patients with PKU because of the deficiency of the phenylalanine hydroxylase enzyme. BH4 is an essential coenzyme that facilitates the conversion reaction of phenylalanine to tyrosine. This reaction is normally carried out by PAH, but this does not happen in patients with phenylketonuria due to their PAH deficiency. BH4 donates 2 hydrogen atoms in the PAH reaction and then is in the less reduced state called dihydrobiopterin, BH4, which is then converted back into BH2, which is then converted back into BH4 by dihydropterin reductase with NADH plus and hydrogen ions as coenzyme. Patient A started using phenylalanine dietary restriction therapy at 14 days of age, She had a good response, and her plasma phenylalanine levels dropped to within the normal range of 1.65, down from her initial levels of 6.6 at 4 days of age. Based on patients' positive response to this treatment, we can infer that elevated phenylalanine levels were caused by her body's inability to properly process dietary phenylalanine, which she may have been receiving indirectly and in small amounts through her mother's breast milk. The inability to effectively process phenylalanine confirms that there is a deficiency in the enzyme PAH in the case of this patient, which is needed to convert phenylalanine to tyrosine. The PAH deficiency has led to elevated phenylalanine levels in the bloodstream, which could eventually cause severe neurologic symptoms, even though the patient may be asymptomatic at this young age. Another patient, who we will call patient B in this case study, is also being evaluated for suspected phenylketonuria. BH4 loading tests were performed on each patient. BH4 loading tests are commonly used to treat PKU patients for BH4, to test PKU patients for BH4 responsiveness. Blood samples were taken at regular intervals following initial BH4 administration. In the case of patient A, the results showed that she was unable to metabolize the excess phenylalanine into tyrosine. The levels of phenylalanine continue to rise when measured in regular intervals following initial BH4 administration. However, patient B's phenylalanine levels decreased with each successive testing following initial BH4 administration. This confirms that a diagnosis of fetal ketonuria is erroneous in the case of patient B, but accurate in the case of patient A. The main way to treat PKU is by limiting the amount of phenylalanine that a patient ingests. They must eat only the amount of phenylalanine needed for appropriate growth and repair of tissues. An excess amount is potentially detrimental and dangerous to body function. Infants with PKU, such as patient A, can usually be fed breast milk because the levels of phenylalanine in human milk have been found to be lower than the levels in any formula on the market. However, a normal mother breastfeeding an infant with PKU must be careful to avoid foods in her own diet that are very high in proteins, such as eggs, cheese, meat, beans, and nuts. Infants with PKU need to consume a formula that is specially designed to contain all the amino acids necessary for their proper growth and development, aside from phenylalanine. Low phenolic is one example of a PKU formula, and there are many specially formulated foods on the market as well, aside from formula for as children grow older. Affected individuals will usually consume a PKU formula throughout their lifetime, along with carefully following a diet low in phenylalanine to manage their symptoms. The FDA recently approved a medication called sapropterin for the treatment of PKU. This medication is meant to help lower phenylalanine levels, but it must be used in combination with a specialized PKU meal plan. It is most effective in children with mild cases of the disorder. Thank you, and that is the end of my case study, Unit 4.